Hello, pharmacists and student pharmacists. My name is Dan Gallipo, and welcome to the next episode of Off Script, brought to you by your APHA ASP Policy Standing Committee. For those of you who are new to Off Script, this podcast is intended to be an informative, interview-based podcast series that encourages our listeners to think outside the prescription pad. This series focuses on the issues that our APHA ASP student pharmacist members determined were important to them based on the resolutions that were passed from the 2017 APHA ASP House of Delegates. Off Script gives us a chance to hear from the experts practicing in these fields to learn more about what we can do as pharmacists to continue advancing our profession. In this episode, we talk about pharmacy benefit managers, or PBMs. Who are they? How do they fit into our complex healthcare system? And why are they getting so much attention lately? And of course, what do PBMs have to do with pharmacists practicing in the community? Today, I am joined by Kevin Schwiers from the National Community Pharmacists Association, where he is the current Senior Vice President of Government and Public Affairs. We are very fortunate to be hosting Kevin Schwiers, so thank you so much for joining us today.
Thanks, Dan. It's an honor. I appreciate the invitation. Happy to be with you.
Great. So I guess the big question first off, what are PBMs? What role do they play, do you see, in today's healthcare system?
Yes, thanks, Dan. So PBMs, or pharmacy benefit managers, essentially are overseeing the drug benefit for the vast majority of Americans. Nearly every American has their prescription covered one way or another through a drug plan that is administered by a PBM. They have relationships upstream and downstream throughout the process. So they are contracting with pharmacies that in the community basis, retail basis chains to which patients go to have their prescriptions filled. They're making all the decisions related to the formulary or list of medication that's covered. They're the ones making the decisions in terms of the copay or coinsurance that patients must incur in order to get their medication. And they determine which pharmacies are in those networks that patients have access to. In addition to that, the largest PBMs own and operate their own mail-order pharmacies, so they're basically also interacting with patients at that level. They're contracted with health plans and health plan sponsors, typically through the health plan, which contracts with the PBM to more or less hand off to the PBM the drug benefit management side of things, where the health plan might focus more of its own attention on the rest of the medical benefit cost. So they're everywhere. I mean, they're in every aspect of the prescription drug system today, and they're impacting every entity throughout the supply chain, and certainly patients and prescribers, and undoubtedly pharmacists on a regular basis.
It sounds like PBMs have a lot of involvement, as you've just said, in various aspects of healthcare, including pharmacies and pharmacists. But why are PBMs now a topic of discussion among community pharmacists and the general public? Why now?
It's a great question. It's a confluence of factors. I think from the community pharmacist perspective, our members, it's been a subject of concern for many years, decades. And what I've seen here at NCPA is in the past couple of years, it's really reached a tipping point related to the amount of interest and awareness about it. I think that I've been with NCPA 8 years, and in my earlier time here, it often felt like we were a bit of a voice in the wilderness, community pharmacists and NCPA speaking about these issues. And then what happened in the last, I'd say, 18 to 24 months has been several factors that has really led this to explode as far as a broader healthcare issue involving multiple stakeholders. And I think a big part of it is the advent of high deductible health insurance plans. So essentially, there was a bit of a watershed moment with this concern related to the price and accessibility for EpiPen, and more recently insulin. And I think that as health plans were asking patients to incur more of the direct costs for these medication, where it was not sort of masked, if you will, through a copay system where they might only be paying a small fraction of the cost. Well, as that manifested itself and those plans became more and more prevalent, more consumers were exposed directly to those costs. And you had greater sticker shock at the pharmacy level as these plans were structured in a way where these patients were incurring all or a substantially greater portion of the cost up front. And that triggered enormous backlash, resulted in hearings in the Congress and a national discussion about how medication is accessed and how do we ensure its affordability. And it's a debate that NCBA has welcomed. We've been calling for it and encouraging it for a long time. And so we're encouraged and excited about it right now, and just trying to hope that this will yield some new approaches in terms of how drug benefit management is considered in this country. And so I think the confluence of gradually rising costs combined with the cost shifting from the plan and the plan sponsor more and more to the patient has made this a front burner issue for a lot of people.
I see. And it sounds like a lot of this discussion is leading towards cost of healthcare and what role PBMs play in that. Now, PBMs are often cited as a way to manage costs, including on their association webpage, the PCMA, who represents them. That's one of their big assets that they put out there, is that they help manage costs. So what do you see in this healthcare landscape as far as costs related to what our consumers or patients are seeing, and then the costs that our payers are seeing as well? How do PBMs play into that?
It's a good question, and it's a question that we think really is open to debate and certainly interpretation. I think that part of the answer to that question is sort of another question in terms of cost for who, and how that impacts the various stakeholders throughout the healthcare ecosystem. I mean, since the incorporation of the modern day PBM around 1987, with the three large PBMs now controlling about 80% of the market, which in our view is excessive concentration, prescription drug expenditures are up 1,010% since 1987 in that period, and the expense per capita is up 756%. So to us, this sort of upward trend, which has increased dramatically compared to earlier years, is a source of concern, and we think one that warrants much greater transparency and a discussion about exactly how that system operates, which we're finally starting to have. I think another thing that's important for your audience and pharmacists as a profession is this concern that we and others have related to the siloing of the prescription drug costs. So for example, there's a lot of downstream health costs that are avoided through better adherence, through better filling of prescriptions and taking them properly. And that's something that, unfortunately, our current system doesn't fully capture and encapsulate. So a lot of the current drug benefit management PBM model is a siloed situation where you essentially have an incentive to not fill prescriptions or have people access their medication because that becomes, sort of quote unquote somebody else's problem, and it's a perverse incentive. And so one of the things that we're trying to work toward is a more aligned, integrated system where there's greater recognition and incentives built in for everybody, for the patient, the provider, pharmacist, that when people are accessing the right drug at the right time, that's something that's supported and not something to which we're enacting barriers.
So it sounds like you're talking about these silos where medication costs are just being looked at as a small part of the whole healthcare cost, which, of course, by addressing medication, but as well as proper use of medication and our involvement as pharmacists in that to help lower the total healthcare costs and to our of course, the patients ultimately in the end.
Right. That's exactly right, Dan, is basically trying to look at breaking down those silos in a more holistic approach in terms of considering prescription drug coverage and adherence as an investment, as something to support and something that will directly result in lower costs and other aspects of the healthcare system, and doing so in a way that where payers and plan sponsors have greater acknowledgement and support for that concept, where instead of the very much siloed system right now. I mean, you consider Medicare program in and of itself, and a lot of what happens in the private sector flows from Medicare. It's its own part of the program, the Part D program. There are some integrated programs with drug and non-drug coverage in Part C, Medicare Advantage plans, but there's still an awful lot of people who are covered just through this silo, if you will, and it's a sort of representative and emblematic of the country's larger issue as a whole.
There was one concept you mentioned earlier. You mentioned transparency. So why is transparency, in your opinion, important? And what is being done now regarding transparency in this system?
Well, not enough, we think, but we're seeing some process in down that path. I think that when you consider how things operate in this part of the economy versus other parts of the economy, it's really a stark contrast in terms of the lack of transparency into the system, and we believe that that does not serve patients or plan sponsors, or in the case of a government program, taxpayers. And so that's something that we're strenuously advocating for, is that there be more transparency. And that, I mean, the more complicated the system is, the less transparent is, does not serve anyone except probably those who are administering the system. And we believe that if you can strip away some of that and get a greater clarity, transparency, that's something that will produce a system that is more aligned in terms of the interest of the plan sponsor, the interest of prescribers, patients, and pharmacists, we think. Whereas right now we have, we believe, a misaligned system.
One topic that we've heard student pharmacists and pharmacists talk about is this idea of the preferred pharmacy. So could you talk a little bit about this preferred pharmacy and kind of what are the issues that you see regarding preferred pharmacy?
Yeah, so about 7 years or so ago, there started a proliferation of restricted pharmacy networks. And so essentially plans were making arrangements with certain pharmacy providers to steer patients toward those providers. And they would strike agreements that resulted in lower cost sharing or co-payments for people if they went to a certain pharmacy provider. And they were done in a way that was not particularly transparent or upfront from the outside perspective, and it became a white hot issue for community pharmacists because NCPA, of course, are primarily the independent mom and pop pharmacies and regional chain pharmacies. A lot of our members are in underserved areas, in rural and urban areas, where chains are not as prominent for a variety of reasons. But be that as it may, the NCPA membership typically serves a disproportionately high number of folks in these underserved areas, and unfortunately we're often left out of these preferred limited network arrangements. And so that became a top priority for the organization in terms of trying to press Medicare, press Congress, interact with plan sponsors themselves in the Medicare program to basically push for greater access to patients and greater choice for patients. So the number of those preferred pharmacy plans has proliferated in the Medicare Part D program. It's now very common, and it is still a source of concern for NCPA because there are some plans, some of the largest plans, which do exclude independent community pharmacies as preferred pharmacies, or where the lowest cost sharing is available. And that continues to be a priority for us. We're trying to get that resolved. We are heartened, at least, though, that there's been a lot of change in the market in response to the pressure that community pharmacists and their patients have applied in terms of the concern about insufficient access. And so now there are at least more options on the market for patients who prefer to use a independent community pharmacy, for them to do so in a way that those pharmacies are able to participate as preferred pharmacies. We continue to believe that more access is needed. As I mentioned, our members serve a disproportionately underserved area, and that's a concern, as well as, and really we think the facts are on our side from the standpoint of there was a very robust debate about this issue with Medicare and officials at the Medicare agency, CMS. They heard our arguments. They heard arguments from the PBM side, they heard, and the plan side. They heard from pretty much every stakeholder, and ultimately concluded that policies that support choice of pharmacy and incentivize the patient to find a pharmacy that works best for he or she is the best way to lower costs and the prescription drug program, Part D. So we believe that that's true, that it sort of aligns with common sense, that the more competition you have, the better and more functioning a market you have. And that's something that we continue to support and advocate for, while at the same time we are encouraged that there's been a market transition in response to the access and choice issues that were really in a bad spot a few years ago.
What is being done now to help mediate the relationship between PBMs and pharmacies, as well as with patients, insurers, and manufacturers?
Thanks, Dan. It's really a multi-track process. So essentially, so much of what the coverage for prescription drug medication in this country is run through some kind of a government finance program or another, be it the Medicare program, Medicaid, or a variety of other systems. And so the discussion cannot really be had without some kind of a level of engagement with policymakers who are leveraging those decisions in terms of access to medication and choice of pharmacy, things along those lines. So that's been a big part of our effort and strategy, is to better educate and inform policymakers to understand the importance of patient access to medication, and that they are able to find a pharmacy provider that works best for them, be it a community independent pharmacy or a chain or supermarket or other provider. That's really kind of a core message that we're taking to policymakers. I think that some other ways that are being effectuated are in the private sector, are trying to find different ways of working with insurers, plan sponsors, and others to try to find better alignment between the plan sponsor, the provider, and the patient. And I'll mention one program which is known by the acronym as CPESN, and so it's a network of community pharmacies of varying practice scopes that are trying to provide a higher level of care for patients, and in doing so in a way that is quantifiable, that adds value to the system, and results in better outcomes for patients. And so that's a discussion we're trying to advance now separately outside of the governmental space, to talk to some plan sponsors and others in the private sector related to how we can be engaged there. And then we feel that there's enormous potential there, and as well as the opportunity for quicker action than, say, in the governmental space, which perhaps maybe down the line will follow when they can see some of the more of these successes happening in the private sector.
As we've kind of discussed, there are potential ways that we can improve on our healthcare delivery service, especially as it relates to the relationship between patients, pharmacies, and PBMs. Is there a better model for PBMs as far as their role within the healthcare industry?
NCPA's view is that there is a need for an entity to manage the drug benefit, and there is that there are benefits that accrue related to that from the standpoint of more efficiency of operation in terms of the pharmacy interaction, the patient getting their medication, the copay structuring. So there are definitely there's a role to play. However, our perspective is that things are completely out of whack right now, and the pendulum has swung way too far from the standpoint of PBMs really being in a position to call all the shots for everybody involved, for the pharmacist, the patient, the plan sponsor. I mean, really in a position of major influence. And so that's something that we continue to be concerned about, and like I mentioned earlier, we're encouraged by the fact that you're now seeing more and more entities speaking out about these issues. We're trying to engage other stakeholders and get them more focused on this as well. So I guess more directly, your question about models. I mean, so this concept of bringing PBMs back to their core competency of claim adjudication and program management is something that we're supportive of and trying to advance. At the same time, so that's a discussion we're kind of having at a governmental level with Congress, with Medicare, with other policymakers. At the same time, we're trying to seek out new models, and so one is referred to as CPESN, and so this is a concept of some pharmacists that are providing a higher level of care than is perhaps typically expected or are accustomed to by maybe the majority of patients. And so we're trying to support NCPA, is trying to support this effort, the CPSN effort of a nationwide network, piecing together different state networks that exist right now or are in various stages of development, to align with plan sponsors to achieve better outcomes for patients and through better utilization of the pharmacist's skill set and ability to help patients. So that's a private sector initiative we're trying to advance, while at the same time having these discussions with policymakers on the government side of things from the standpoint of how do we have a system that, again, better aligns the interest of the patient, the plan sponsor, the pharmacist, providers.
How can student pharmacists get more involved in PBM-related issues?
Well, I think that getting involved in their organizations, their trade associations, is really where they have to start. And so, APHA is a great organization. NCPA does a lot of work with them, and we have a great relationship with APHA. We have a very active student contingent of NCPA members as well, who are really some of the best and brightest and doing some great work. And we'd encourage folks who, particularly those who are either concerned about these issues and those who might have an interest in the independent pharmacy space down the line, to get and to stay engaged, with their associations. We're really the only entities that are out there kind of speaking for them on these issues, and so I think that having their engagement is critical to the process. I'd say some resources that I would recommend would be on our website. It's www.ncpanet.org/advocacy, and there you can find one-pagers on a lot of these issues that we're talking about, as well as links to how people can take grassroots action to contact their elected officials to advance some of these pro-pharmacist, pro-patient proposals that we're advancing.
Thank you so much. I'd like to thank Kevin Schwiers yet again for meeting with us today as we have our discussion about PBMs and how they relate to pharmacy and pharmacy practice out in your... Thank you yet again to Kevin Schwiers for offering to speak with us about PBMs and their impact on pharmacy. We, the Policy Standing Committee, would also like to thank all of our listeners, including pharmacists and student pharmacists. And remember to take a few moments each day to think outside the prescription pad.